Thank you. Yes, just to let you know that this will be recorded and will be made available with subtitles afterwards. So just so anybody that wants to be able to look at it afterwards, you can have a look. Oh, bear with me a moment. Technical hitch with my presentation. Okay, so actually what I would like to do now is just run through the panel. So panel, when you see your name, if you'd like to just unmute yourself and then introduce who you are, that would be great. So first of all, we have Professor Sir Munir Pir Mohammed. If you'd like to just unmute and say hi and who you are.
Hello there. Good evening, everybody. My name is Munir Mohammed. I'm a professor of medicine at the University of Liverpool and a member of ARDAT. And what we are particularly looking at is side effects associated with gene therapy.
Thank you. Dr. Catherine Baggott.
Hello, I'm Catherine Baggott. I'm a consultant haematologist in the Glasgow Haemophilia Centre. We are currently setting ourselves up in Scotland to be able to give gene therapy. Glasgow will be the centre that gives gene therapy, and then patients from around Scotland who want to have gene therapy can be referred in from any centres in Scotland. We've also taken part in gene therapy trials over the last 10 years for patients with haemophilia. So nice to see you all here.
Thank you. Paul Batty, Dr. Paul Batty.
Hi, I'm Paul Batty. I'm a haematologist based at the Royal Free Hospital in London. I also work at University College London and have an academic interest in how gene therapy works, with a particular focus on safety. So thank you for inviting me to join tonight.
Thank you. Dr. Guy Maces.
Hello, everybody. My name is Guy. I'm a clinical psychologist. I'm based in the Royal Free, and as part of my role, I get to speak to every patient who decides to go through gene therapy. So looking forward to this evening.
Thank you. Ed Lee.
Good morning, everyone. My name is Eduardo. I'm one of the nurse specialists at St. Thomas Hospital. So we are one of the hubs in London that had initiated gene therapy early last year.
Thank you. Brian Mahoney. Oh, Brian, you there?
Yeah. Hi, Brian O'Mahony. I'm the Chief Executive of the Irish Haemophilia Society, former President of WFH and EHC, and I took part in a gene therapy clinical trial just over 6 years ago.
Thank you. And Joseph Dulac.
Hi, my name's Joseph. I have severe hemophilia B, and I had gene therapy back in November 2025, so just a few months ago, and I'd be happy to share my experience with you all.
Thank you very much, Joseph. My apologies, I should have introduced myself as well. I'm Deborah Morgan. I'm Head of Policy and Campaigns here at the Haemophilia Society, for those who don't know me. And also, Pradeep, do you want to say hi as well, who's also one of the organisers on here?
Hi, my name is Pradeep. I'm a researcher working at the University of Liverpool with Sir Munir Mohammed.
Great. Thank you very much, panel. So just as a quick rundown, what we're going to do is Brian is going to talk to you first about his experience of going through gene therapy on a trial. And then afterwards, we're going to go to Guy and Joseph, who are going to go through Joseph's experience of having gene therapy as a commission therapy. Then we're going to come to Eduardo, who's going to talk from a nurse perspective. He's dosed people at St. Thomas's. And then we'll have the expert panel for a Q&A session. But don't let that stop you from asking questions along the way. Feel free to ask questions. That's fine. You don't have to you don't have to wait till the end to do that. So, and with that, I will hand over to Brian, if that's okay.
Thank you, Deborah. I guess about 12 years ago, we started trying to encourage companies to come to Ireland with clinical trials for new therapies and also gene therapy. So we had several of the companies come over and we did meetings. We typically would do a meeting with the company, with a clinician, with a group of patients to gauge the level of interest. So I followed the science very closely due to my job and also due to my interest. And I came to the conclusion from looking at the results that gene therapy was a therapy that for me had a positive benefit risk ratio, and I was prepared to try it. I spoke to, I suppose, an unusual pathway because I have a lot of contacts to community. I spoke to a lot of really good clinicians who were friends. I spoke to people with hemophilia who were leaders in various organizations. I got a range of opinions as to whether or not they thought this was a good idea. In terms of my rationale for taking gene therapy, um, I like the idea of having a constant, hopefully decent factor IX expression level, which would allow me to stop prophylaxis, would perhaps decrease the amount of chronic joint pain I have in damaged joints, increase my physical activity. Also, the fact that at the time I was 62, and I was concerned if it took several more years to get it licensed, that I might be aged out of the opportunity. And finally, I wanted to try life without severe hemophilia. Any of us with hemophilia have been born with hemophilia, always been our reality. I thought it'd be quite nice to try life without it. My expectations going in, I was hoping for a factor IX expression between 20 and 60%, ideally not having to use steroids. I was hoping for a decrease in joint pain, an increase in physical activity level, and also spending less time on my own hemophilia and managing my own hemophilia. The process that the process was the infusion process is very simple. It's a total anticlimax. In fact, it's a couple of hours with an infusion. You still wait 3 hours afterwards. I was much calmer than the clinical team, so I thought it was absolutely simple. Now, obviously, the follow-up, especially in the clinical trial, is quite complex. Now, there were a lot of monitoring visits, especially in the first 3 months and in the first year. But this does not and should not come as a surprise. This is all explained very carefully beforehand. So whether it's a clinical trial or a licensed gene therapy, I think you have to make the commitment to adhere to that follow up, certainly in the first 3 months in the first year. So it does take some time and planning. Um, Obviously, there are a lot of uncertainties in terms of long or short term safety, the durability, how long will it last, predictability, how many people will, what percentage of people will not get a response, what factor expression you'll get, and so these were all uncertainties. At the time I was going into this, we only had the phase 2b results, so I was basing my decision on the results from 3 patients. So anybody now getting the licensed factor IX gene therapy is basing it on a phase 3 trial, which was 54 patients. So it's quite a difference. Now, as I said, I'd set the expectations I wanted, but I was also very clear in my head that if I didn't achieve these expectations, I was prepared for that. So, if I was hoping for a factor IX expression between 20 and 60%, if I got 5% or 130% or 2% or 160%, I was mentally prepared for that, I think. I would not have been as pleased, but I was prepared for this. And I understood that with the uncertainties and with no way of predicting which individual will get which response, I think you have to prepare for a range of potential expectations going into the process. So I'll stop there for the moment and hand over to Guy.
Thank you very much, Brian. So now we get a chance to hear from Joseph. So Joseph, I'll let you introduce yourself to this audience.
Hi, my name is Joseph. I have a severe hemophilia B, and I was the first patient to get the licensed product at the Royal Free Hospital. It's been quite an experience, but I'd like to share my experience with you all. Like Brian said, I had to set my expectations as well. Um, I'm quite an active person, and do a lot of sports, so. I wanted to be able to push myself a bit further without getting all the injuries that come with hemophilia. And I also wanted to be able to travel a bit more and explore the world without having to travel with my injections in my suitcase, having to be stopped at the airport quite a few times over my life. It was something that I wanted to do. Yeah.
So probably if you can go back to the beginning, when was the first time you've heard about gene therapy?
Oh, it was quite a long time ago. I was around 16, 17 year old, so it would have been 10 years ago. And my clinician at the Royal Free mentioned about the trials, and that it could be an option for me as soon as I turned 18 years old. I was also already on quite a heavy treatment process with as I did a lot of sports. I did fencing to quite a high level, so I was already being followed quite well by the hemophilia center in the at the Royal Free. But yeah, 10 years ago, I would say.
And I guess when did the first conversation really started about it?
The first time I think I met with Dr. Batty would have been in 2021 or 2022. We got the conversation going, and obviously after that the COVID happened. So it was during COVID, so it wasn't the priority, I guess, for healthcare professionals. But yeah.
Up until that point, what was that? What did that feel like for you?
Well, I've always been quite active, and I really wanted to do it if it could improve my lifestyle for for a bit. I thought, why not? Let's do it.
Any concerns or any fears going into this?
Well, there's always a bit of concern, but I've always been quite positive about the experience, and I put my trust in the medical evolution of things. My sister's a doctor, so I was able to speak a lot with her as well about it, and she could explain to in I'm going to say simple person ways to explain what the science behind it was and the risk that come with it as well. And for me, it was a risk I wanted to take.
Okay. Do you remember what was the deciding factor for you?
The deciding factor, I don't think that was really, since I heard about it, it was already pretty straightforward in my mind. I really wanted to go for it. And I thought it was an important thing to do for myself, first of all, and also for the next generations of hemophilia that gonna come after.
So if you can take us a few hours or a few days before the infusion day, what was going through your mind?
Uh, well, it was a big build up to the infusion there, I would say. You know, I went a bit on a healthy streak of losing weight, eating well, stop drinking as well. I wanted to put all the chances in my basket, so I took it quite seriously, and uh, it was very exciting. I would say a bit nervous as well, a bit nerve-wracking, but very exciting.
Anything specific that you remember from the day itself?
The day itself, well, you get a bit nervous when you have the cannula in, and then you see quite an expensive product. So when you see the gene therapy itself arriving, and it was quite impressive to see. But then the actual infusion itself was a bit very anticlimactic, I would say. I didn't get any reaction, so that's a good thing. Um, and yeah.
Just as before that, you said you talked about the adjustment. I mean, as you said, you're not supposed to drink. How did you find that part?
Well, yeah, it's a bit of a it's a bit of a sacrifice where you know that you're gonna have to be going to into hospital quite a lot, and organize your life around it for up to a year. So I was ready to do that. I'm lucky enough to be working for myself and with my mother. I have a family business, so it was easier for me, I guess, to get into it and be like, well, if I can't be there for today for work, it is what it is.
And how did friends and family, how did they react to your decision?
Well, they've been very supportive. All my friends have been very supportive. My family as well. My sister was there as well for on the treatment day. My parents came to see me as well. So it was it was a family decision as well. It wasn't just mine because I've been living with the hemophilia myself, but they've also been living with me having hemophilia for the last 27 years. So it was yeah, but overall they were a good. They were gonna support my decision in any case.
Okay. So I guess after the infusion, if you can tell us a bit what's the experience like was for you after that?
Well, the it's very time consuming and a lot of energy. I live quite far from the hemophilia center in at the Royal Free, so it takes me about an hour to go there and an hour to come back. So Uh, that it would take when I was needed to go twice a week, I calculated about 10 hours of transport and being at the hospital a week, which on top of work can be a lot to handle. Also, if my liver function would go up a little bit, I would have to come back the next day. So drop everything I would be doing and just go to hospital and make sure everything was okay. Um, I think uh, I think I was quite very lucky to not need the steroid treatment. Um, and yeah, it's very time consuming and it takes a lot of energy, but I think if you get to the point where you've made it that far, you take it you take it upon yourself to go and take everything seriously.
And at that point in time, you're both managing all of the requirements, the time requirements, and also the uncertainty of kind of waiting to see how it's going to turn out. What was that like for you?
At first, well, when I wouldn't get the results from the hospital, I would call and see if they were good or no. I think for me, it was better to know if how my levels were doing. And well, now I can say that I'm on 20 around 30%. My factor 9 levels are around 30%. I've not had to inject myself since the 12th of December uh, to anything related to hemophilia. I did have an incident where I did hurt my back, and I did do a treatment because I wasn't sure if it was a bleed or not. Turns out it wasn't. But I've not had any hemophilia related injuries since then. So it makes me happy to know that. And now I'm just trying to rediscover a bit how my body works and what the pains I'm feeling are they related to my hemophilia, or is it just for instance a runner's injury or just getting older, I guess.
And how's that process been like?
It's been so I've been running a lot, and I've actually signed up for a half marathon to run for the Hemophilia Society in October, and so I've been getting little nibbles with my running injuries, but nothing to do with the hemophilia. So I'm lucky enough as well to have the physio at the Royal Free to help me prepare for this race, and yeah.
Anything else at this point in time that you feel differently has changed in your life since?
Well, it's nice. It's nice to not have to inject myself most mornings, and now I'm looking forward to be able to go on holiday and enjoy some sunshine, as it's been a very cold and grey winter in the UK. So yeah, that's my next thing I'm looking forward to.
Excellent. So just two final questions. Looking back at this, what would you say, the most challenging part or the most challenging aspect of the whole process?
I think the most challenging part would be the follow-up, um, blood tests, going to hospital. There's some days you're not feeling like it, but you still have to. So I think that would be the most challenging part, and then waiting for the results and do I have to come back tomorrow or not? That was for me, it's been the most challenging. Um, and yeah, it just takes a lot of energy, and your whole life is kind of centered around that for the moment. But it's up to you to make the best out of it, I guess.
Is there anything that you would have liked to know that would have been helpful to know in hindsight?
No, I was mostly aware. I've been told all of this. It's just sometimes you think you can handle a little bit more than you actually can. So it's been a battle, but I've been happy to do it, and it's been going the right way for me. So I'm very pleased with the experience so far.
And so my final question, if somebody would come up to you and ask you, tell you that they're considering, what would you tell them?
I would tell them that it's important to put your expectations up. Uh, well, to write down your best case scenario expectations and your worst case scenario expectations. And for me, my worst case scenario was, well, life goes on as an hemophiliac, and you carry on doing your treatment. But like that's what I think Brian said as well. It was quite a similar, but for me, it was worth taking the risk. Can I improve and make sure I don't need to, if I'm not gonna need an injection unless I have a very bad accident or surgery or something like that. So I'm pleased with that, and it's I would tell them you have to be ready and mentally and physically to do it.
Excellent. Anything else that you would like to add in this point?
No, I don't think so. I'll- If you have any,
Good. I'm sure there'll be lots of questions. I'll hand it over back to Deborah.
thank you.
Yeah, thank you so much for that. That's really, I think it's so interesting to hear from somebody who's been through there. We look at all the theory but to actually hear from somebody who's been through the process, I think is absolutely fantastic. So please, anybody's got any burning questions, put your hand up, wave at me if your camera's on, or write something in the chat. But I'm going to take privilege as host to ask the first question, Joseph, to you. Did you actually, when you were explaining to friends and family, how much detail did you have to go into about what is gene therapy? Did they really quiz you, or they just sort of, how, what did you have to tell them? Did you have to up your knowledge to explain what it was?
Well, so like I said, my sister's a doctor, so it's a good thing to have that, so she could explain it in normal people science in a sense. And so the thing I would say is, for me, the image I've had in my head of gene therapy is, this is going to sound really weird, but it's at the start of Spider-Man when he gets bitten by the spider, they add a piece of DNA to his whole DNA thing. So for me, it was yeah, I kind of explained it in that way, in a fun way. Um, and yeah, that was my way of explaining it, and or just saying it was like an add-on to my DNA, on top of that would teach. It's a virus that teaches your liver to produce uh, your factor 9 essentially. That's the way I would explain it.
Brilliant. Okay, thank you. I don't think it's only for the Bonycote family. I think that's how you pronounce your name. I think you said your levels went up to about 20%. We'll come on to what's expected later when we'll bring in some of the clinicians. But just for you, is that what your expectation was, or did you not have an expectation of what the level was going to be?
I didn't have a particular level in mind because I'm obviously, as a severe hemophilia B, my levels were always at 0, and with my regular treatment, it wouldn't go up that high. The highest that's been recorded, I think, was 33%. So now it's not unlikely it will go higher if Dr. Batty will correct me if I'm wrong, but it's unlikely to go higher. So I've been the recent test I've shown in between 28 to 33%.
Great. And actually, somebody's asked about monitoring levels, and you might want to, Paul, you may want to come in as well. How often do you will have to monitor your levels now, and how often is that going to be in the future?
So the first 12 weeks was I was going in twice a week to monitor my levels, and now I go in once a week to monitor my levels. And then I think it goes to once every 2 weeks, and then once every month, and later on down the line.
Yeah, that's right. I mean, I think the early part is quite intense with the monitoring. I think for Joseph, we're really trying to be careful to avoid steroids, so we were a bit more cautious in terms of the monitoring. I think one thing, Joseph, one thing I remember is this happened around Christmas as well, didn't it? Which was with timing of the infusion was sometimes a little bit more challenging working out the dates as well. But yeah, the first 3 months is the really more intense time.
Great,
Just to say,
great,
after the first year, Deborah, it's every 6 months, so it's much
excellent,
easier.
Yeah.
great. Thank you. I can see we have a question about haemophilia A, and we'll come on to that later if that's all right, James, because I think there'll be more questions we can put to the clinicians. And now I think I'm going to hand over to Eduardo, if that's okay, who's going to have just a quick rundown of what actually happens on infusion day. Hattie, I'll come back to your question afterwards if that's all right. I'll hand over to you.
Thank you, Deborah. I'm just sharing my slide. Okay. Can everybody see that? Yeah. So, thank you again for inviting me today to share our experience in initiating gene therapy and St. Thomas's. So, just to briefly look into our pathway basically on the day. So, as everyone has mentioned, that there's been a lot of prerequisites in terms of laboratory tests and ultrasound, including antibody tests, before we initiate the infusion. So I've put there that the consent should be formally to have the second consent on the day of the infusion, which the consultant will perform or initiate the eligibility as well, in which we have already prepared the um, ITU team to be informed ahead of the schedule in case of emergencies and so on, though we did not have any on that day, in which once we have received the second consent and all the checks are in place, we will signal the aseptics team to prepare the medication. So we start at 7:30 a.m. So our patients have been pre-admitted the night before, as due to the time as well as the logistics on the patient's address or location. So once that's being prepared, we ensure that there are two cannulas in situ in place for the patient, one for being the gene therapy itself, and the other is for side effect reaction and emergencies. And we have utilized an A and B line pump on that day to avoid spillage issues and for more seamless infusion as well as flushing post infusion. And do expect the for the patient to be infused over an hour, as well as continuous monitoring up until 3 hours post the commencement of the infusion. And after the infusion itself, we have assisted the patient to go to the ward, in which our consultant have prepared a reactive prescription for steroid regimen in case that there are any liver function elevation whilst being at home. And of course, we have coordinated with the patient on the follow-up appointments in regards to their blood tests. As you could see on the post-infusion follow-up directed on the right here, that there are we do ask the patient to commit a 2 weekly or bi-weekly appointment for the levels as well as other blood tests. That gets tapered off for the next 3 to 6 months, in which we expect them to be in every month, and then quarterly from 6 to 12 months. And that also includes ultrasound as for the first year up until annually 2 years after. And of course, there's a continuous handover to the national and regional MDT in regards our patient update. And for our particular experience, I think the gene expression is around 30% update. And of course, all pertinent information will be managed by the UKHCDO for recording. Basically, our key learning point is one, early engagement with commercial teams, since it is crucial to manage contract negotiations and prevent project delays. Or timely patient identification, just to streamline the patient pathway itself and other preparations. Efficient consent process, since it is quite lengthy, and a proactive planning, and of course, communication is quite crucial. And of course, robust governance framework will ensure compliance, enhance patient safety, and provide efficient operational oversight. And teamwork and communication is essential as well for coordinated patient care. And lastly, resource allocation, which is really paramount in the effective infusion and the preparation of the administration. So yes, that is our experience with gene therapy. So it's I'd like to thank our team as well as our patients to sharing their experience on this one. And yeah. I will hand over now to our next speaker.
That's fine. You can come back to me. So thank you so much for sharing that. Please do carry on adding in your questions. I'm just going to go back to a couple of points that were raised. Not necessarily in the order they've cropped up, but actually interestingly, somebody's made a comment about they have a 1-year-old. I think that's Hattie, isn't it? So what about children? I'm not sure who wants to answer this, whether it's Catherine or possibly Paul. Are there trials for children? What are your thoughts about gene therapy for children, or are they pretty much going to wait until they're 18?
I can chip in if you want to on this. So at the moment, gene therapy is only available for adults. One of the faults with the current type of gene therapy is that because it doesn't become fully part of someone's cells, that if you treat it too early, it might stop working. So there are studies that will be starting, but they will clearly be sort of inching down in age. So from just below 18 before they get into younger children. I think it's something that will happen in the next few years, but I think clearly within this situation, safety is always the most important thing. So we need to see what happens and make sure this is important. And also talking about gene therapy with kids is very different to adults as well. And it's a long-term treatment that's irreversible. Catherine, did you have any thoughts as well?
Yeah, I think we're still learning so much about gene therapy. So I can never quite remember exactly what the date is now, but we're probably looking at sort of 16, 17 years since the first patient, any human in the world, received gene therapy. And for the sort of greater number of people, we sort of talked about numbers like 54 and 40 and things like that. So that these people have only had follow-up for maybe 6 or 7 years. So there's so much we don't know yet, and we've got a lot to learn. So I think as we get more and more experience and people have longer and longer follow-up, and as we get slightly different therapies, I know we've just been talking about gene therapy. The gene therapy has been talking about, when it comes to Brian's experience and Joe's experience, is just getting the factor 9 gene into the liver cell, and then the factor 9 is made. What we're now looking at is whether in newer trials is whether we can actually get the factor 9 gene into a gene. And these technologies are going to take time. So I think probably as clinicians at the moment, we think let's get lots of data on adults, maybe through trials we may be able to get slightly younger. We often talk about people over the age of 12. So, it's going to be a very, very long time before we're giving gene therapy to, say, a 1-year-old. I couldn't tell how many years, but I think it's going to be a number of years as we get more data.
And Guy, I mean, it must be an interesting thing if you're going to give something like a gene therapy to somebody, if you have permission, especially if they are technically a minor. And from your perspective, that must have some challenges as well.
I think that's one of the discussions that we've had initially when it was just kind of presented, because the idea is how, first of all, do you make sure that somebody is going through a life-altering therapy that only potentially has one chance to do it? So how do you really have a very ethically informed conversation with them as a kid to make sure that you are doing it for the benefit of the child in this regard? So I think that will pose a lot of ethical questions that will be a big part of the discussions with that aspect moving forward as well.
Absolutely, thank you. There's a couple of questions about side effects, but I just want to bring in one other point first before we move on to that, because I've got some other questions that people have also emailed in around that point. But there was a question about for you, Eduardo, about how many patients have you treated before we started? And I know we're early days, so how many have you done so far?
So we did one last year, and we are anticipating 2 this year.
Great, thank you. The other thing I want to put, so again, this is probably a Catherine and to Paul, is those people, as you're at the main centres, so you're at the centres that do both the dosing and the monitoring. Now, I believe there are people that have been dosed that their main centre isn't a gene therapy dosing centre. Do you want to explain how that works so that people across the UK, what their options are if they don't live or aren't? Their main centre isn't a gene therapy dosing centre. I'm not making myself clear, but I'm sure you can explain better than me.
I don't know whether, so I'm from Scotland. I wonder, Paul, whether you should sort of talk about, because you've got your regional centres, and I can obviously add stuff on about Scotland. I wanted to talk about England first.
Yeah, sure. So I guess within the London region, there's two centres that are allocated as dosing centres, which is the Royal Free and St Thomas's, so one north and south of the river. We coordinate as a pan-London group, so we have a regional meeting to look at advising on treatments, but we also have interconnecting hospitals that where people are looked after. Say, for example, for ourselves, there's the Royal London, which is in East London, and also Imperial, but also centres just outside. So within this, obviously, we want to try and make the process as straightforward as we can because long journeys is a huge burden, as Joseph mentioned, in terms of travelling up to the centre. So this gives, I guess, a couple of options, and it's also, I think, important to have some of these discussions with a doctor who you know and trust as well. Whereas if you're going to another centre, that's a different dynamic that you will have to get used to. So it varies a little bit in terms of the centre's experience. So the Royal London, for example, has been involved in quite a few of the clinical trials, so has experience of monitoring quite closely. So we will probably work quite closely with the Royal London to help with doing an infusion at the Royal Free and then allowing follow-up more locally. The other thing which I think will probably become available is home nursing services. So for people that are based a little bit further out to allow not having to come to the centre and have the blood samples taken in the community rather than in the centre, which I think does in other parts of London where the distance of England where the distances are bigger, that could be quite a benefit as well. I think there's no sort of one size fits all though, and I think it's making a balance between what people's needs are and in terms of and where they're based as well. And I think and which centres are also there is some overlap between different regions as well.
Yes, thank you very much. And somebody just put in the comments there that they're going to Birmingham for the therapy, and if it goes ahead to Bond by Leicester. So there's a good example of how that works. And if you are interested, go and talk to your centre and see what the options are for you. Catherine, do you want to speak about Scotland?
Yeah, and I think what Paul said about how one size does not fit all. So I think it depends. So for example, so I'm in Glasgow. We are the only haemophilia centre in the whole of the west of Scotland. So we cover actually right up to Shetland. So it really depends. Are you someone who just lives on the outskirts of Glasgow, or are you someone who lives right down in South Glasgow or somewhere up near Oban? And your nearest haematologist may actually know nothing about haemophilia, but they may be able to monitor your blood tests. And so in that situation, Glasgow can be incredibly involved counselling the patient, but we'd hope that we can then do the blood tests locally with the haematologist, often giving it a huge amount of advice. So the communication happening at that long distance rather than the patient travelling long distances. But then it may be someone who comes from Edinburgh, which is a comprehensive care centre, huge amount of experience with haemophilia. They will probably do a lot of counselling for their patient already, and then the patient will only come to us for dosing. So it really isn't one size fits all. And that is going to be very much part of the discussion that we have with a patient who's thinking about gene therapy, their local haematologist, their local haemophilia doctor, and with us, so that we can try and do a plan in terms of the monitoring that works for them. So yeah, one size does not fit all, and it can be talked about in the sort of counselling process before gene therapy is, when it's first being considered.
Great, thank you very much. Obviously tonight we are talking about haemophilia B and gene therapy, but somebody has asked about A, and we know there have been trials in haemophilia A, but there are some more hurdles to come across that. Does anybody want to comment on haemophilia A gene therapy? Brian, I can see you.
Well, it's not an option at the moment because originally the company decided to market it only in the USA, Italy, and Germany, and now they've stopped marketing it altogether. So for the moment, there is no available hemophilia A gene therapy. Although there are, Paul can talk about this, there are other factor VIII gene therapies going to clinical trials.
Yeah, so just to add to that, the vector that was available in the US and Italy and Germany is that the company is going to cease production of that vector in the next few months. This is not due to any safety worries about that vector. This is made due to commercial decisions from the company, and it has made a massive difference for many men's lives who have been treated with this. So I think in terms of the horizon, really for haemophilia A, there really is mainly just clinical studies, which will probably be initiated in the next year or so. But it still could be an option in that sense.
Yeah, thank you. So there was a question directly to Joseph about did you have any lasting side effects after the infusion? But I think it might be good perhaps to just talk about other sort of side effects in general. Joseph, I don't know if you're there. Do you want to make any comments? Did you have any lasting side effects at all?
I did not have any side effects at all. Um, the Royal Free Center were ready in case I did have an allergy to the treatment, which did not happen. So, but no, yeah, no, nothing happened. I've pretty much been normal ever since.
Great, thank you very much. So I just wanted to ask, there's a couple of people had emailed in questions about side effects. And somebody had asked specifically if there's any understanding of the effect on people who already have cirrhosis of the liver following Hep C. I mean, can that preclude people from it?
Unfortunately, so the liver cells have to work. They have to be functioning effectively. And so if you have bad liver disease, then it would be inappropriate to give it, because you'd be giving a gene therapy that almost certainly would not work because the cells are not functioning properly. So unfortunately, if you have cirrhosis, you are not eligible for gene therapy.
What about if you've been infected with Hep C, but you haven't had any significant liver scarring?
That's fine. That's fine because you've got a functioning liver. So yes, unfortunately, you had hepatitis C. You were treated. The hepatitis C has now been cleared. Your liver monitoring has demonstrated you've got no long-term liver damage, and therefore you can safely receive gene therapy.
Okay, and do I take it that's the same if you've got HIV and that's been controlled?
Yes, you can as long as your HIV is controlled, you can receive gene therapy. The most important thing is having a very, very healthy liver. That's the thing that's really, really important. This is why if you really don't want to be drinking alcohol after you receive gene therapy for the first year, which for a young man like Joseph, I'm sure that was sort of something he really had to think about, because you can't just sort of say, oh, I'm going to have a couple of beers, it'll be all right, because that would be terrible if you then inflamed your liver and you lost some of the gene therapy. So yeah, liver disease is absolutely paramount. Sorry,
Can I
liver
just
health is
ask?
paramount.
Can I just ask Catherine and Paul as well? I mean, I think another perhaps liver criteria that we're looking at the moment is fatty liver, because I think quite a number of people with hemophilia, as indeed the rest of the population, might have fatty liver, and that may prevent you getting gene therapy in some cases. Isn't that correct?
I think you've got to think so from my point of view as a clinician, let's say I have a patient who's considering gene therapy and they have their FibroScan, which is a way of sort of measuring liver health, as well as just a simple ultrasound scan of the liver. If that demonstrates a fatty liver, which you can see on these things, and let's say they are overweight, then I would then start to talk to the patient, maybe if you want to try and make this gene therapy work as well as possible, maybe it'd be worth waiting 6 months, a year, 2 years, bring the lose some weight, rescan the liver. Okay, it's not looking as fatty. To give, because as we've all talked about, this is a one-shot event, because once you've had the gene therapy, you will develop antibodies to the virus coat that you've been given, and you won't be able to receive it again. And the type of viral coat, it's not a virus, but the type of viral coat we use at the moment, you will make antibodies to that, and most of them are based on a similar type of viral coat. So even if there are other gene therapies that come out with that same sort of viral coat, you probably will have antibodies to it and won't be able to receive it. So I think, when we're doing all the counselling for the 1 or 2 years beforehand, because we do talk about the patients, I've been talking to patients for years now about gene therapy, and they're still sort of deciding, is it right for them? Because it's such a big decision. During that time, become as healthy as possible. Reduce how much alcohol you're drinking, have an optimal weight. These sort of things are probably going to make the gene therapy, give it the best chance possible. Nothing can absolutely predict, but just give it the best chance possible.
Yeah, it's really interesting. Joseph, there's a couple of things that are coming. I think you'd be able to answer. And one's about sort of work-life balance and the follow-up and how easy is it to do that with all these appointments. And then there's also about, are you advised not to drink alcohol at all if you receive gene therapy, and how long have you got to stay off the drink?
Well, uh, yes, you can't drink while you have gene therapy. So I just to help myself to get, like I said, um, I started in September to get living a healthy lifestyle, so doing a bit more sports. I lost some weight, and I stopped drinking altogether. I just went cold turkey and went on a summer holiday, and then came back to London, and that was it for me. And I'm not even sure I'll go back to drinking now that I've, lived this lifestyle of healthy, healthy living in a sense. But yeah, and I don't really miss it that much. My friends are quite supportive of it, so we just do different things, and that involves maybe drinking a lot of coffee instead of of beers. But there we go. Yeah. And I think there's another question about the influence on your body, health, liver. I don't know if anyone else wants to answer that.
Yeah, I was just going to come to Brian. What did you think about the did you have a drink afterwards, and then we'll come back to the.
Yeah, I mean, the advice was not to drink for a year after gene therapy. So, with an abundance of caution, I didn't take any alcohol for 3 months before the gene therapy or for 2 years afterwards.
Yeah.
As Catherine and Paul said, you have to give it every chance to work.
Yeah, I agree. I agree with you, Ryan.
Yeah, yeah. Okay, so I think these two are quite interesting. So, how will gene therapy influence your body, health, liver if the therapy doesn't work? And we do know there are instances where the expression is quite low. Who wants to tackle that one?
So, if the gene therapy doesn't work from the point of view of producing very much factor nine, the studies, again, it's still quite small numbers with the main study being 54 people, and that's been reported at 5 years. From the earlier studies from how that was developed, the follow-up has been for over 10 to 15 years. And I think from the point of view of there's been no safety concerns from people who have and have not had expression in there so far. So I don't think it probably, if the gene therapy is still around, then even if it's at a tiny amount, it still could potentially, it's still there. If it's there a little bit more, then I guess it's still there as well. So I think there's nothing that's, if it's completely gone, then it's gone now, I think. So it's kind of, there's not really a specific answer. Don't know if anyone else wants to sort of add to that maybe.
Yeah, I think obviously I could be reading the question slightly wrong. I think the question is, has the gene therapy somehow damaged your liver if it hasn't worked? I don't think we've got any evidence of that. I think the one thing that we all sort of in inverted commas sort of worry about, what exactly the future holds. So we've got all this long term, well, we've got a small amount of long term follow up, and we do know now that some of the genetic material that's around the factor 9 gene in this viral coat, it does incorporate itself into patients' DNA in tiny, tiny amounts. We do know that happens. And the question is, does that put you at any increased risk of cancer or not? That is the really, really big question that no one's going to be able to answer for the many, many, many years. And I think whether the gene therapy has worked or whether it hasn't worked, we've got no evidence that, you're likely to have more of this little incorporations of genetic material if it has worked or if it hasn't worked. I mean, what we're trying to do is, if anyone, because unfortunately cancer is really, really common in the general population. So, about 1 in 2, 1 in 3 of us are going to get it. And what we're asking patients who have gene therapy is not as part of trials or anything like that, but if you do need to have a biopsy for any reason, can that be looked at to see whether your gene therapy might have had any involvement in that at all, so that we can learn as time goes on, so that 5, 10, 20, 30 years from now, we will have a much better understanding of whether this is increasing your risk of cancer or not. I've sort of gone off course a little bit, but it's just to sort of say, that there are these safety things that we absolutely cannot answer until we're sort of 20, 30, 40 years down the road. And that's what's very hard for patients, I think, is that level of uncertainty. So, as Joseph described and Brian's described, it's all about what's right for me, what isn't right for me, what risks am I prepared to take, what risks am I not prepared to take. And for some people, Joseph, he's very young, and hopefully, he'll be able to live a life free of many, many issues now. For him, he's obviously balanced that risk benefit that, if when I'm 40, 50, 60, am I slightly increased risk of cancer? Then if I hadn't had gene therapy, that question will not be answered for years and years and years. And that's a level of uncertainty that no one can answer. And it's something that, we all have to live with, and something has to be considered if you're going to have gene therapy.
Yeah, thank you. And I think that sort of answers as well the how long does gene therapy last if you can only have it once? And yes, it is not reversible. I think on the trials they have to do an estimate, and I think they were looking at sort of 10 years. Correct me if I'm wrong there, as being a sort of minimum. But Paul, did you want to comment on that at all?
So within the trials for haemophilia B, I mean, the levels have been pretty stable at over 10 years. So from the initial studies, this is in the precursor to the current gene therapy vector, but the guys who went to that levels have been very stable. And I think within the 5-year follow-up, things very much look like a straight line. This is different for haemophilia B to haemophilia A, though. I mean, on haemophilia A, clearly there's nothing available in the UK at the moment. For factor 9, it seems to be the liver copes with making this better than factor 8. So my guess is that it will last for hopefully many decades, but at the moment, I guess we need to have that time to be able to tell us.
I just add to that I had gene therapy just over 6 years ago, and my factor 9 level has been very steady over that 6 years. And as Paul said, if you look at the 5-year results, which are recently published, it looks very much like a straight line, whereas the factor 8 went up and then it certainly went down consistently. And as Paul said, well, one of the earlier trials in the UK, they're now about 13 years post-dosing people, and the factor 9 levels are still fairly consistent. And the mathematical model that the company used for the current licensed gene therapy estimated the vast majority would last 25 years, but that's a model.
What is the oldest patients you've given gene therapy to? Does age have an impact? I'm 66, and we've also had somebody who said they're in their 60s as well that has asked the same question. So is age a factor? Is there an upper limit?
In one of the trials, I think it was one of the 9 trials, the oldest person was 75. I don't know if governments are applying or payers are applying age limits. I was 62 when I got gene therapy. So I haven't heard of governments applying age limits. I would be, if I was 75 and looking for gene therapy, I'd be very nervous that my payer wouldn't want to pay for that. But certainly, I think 60s should be okay, I would think. Paul?
Yeah, absolutely. I mean, within the main study, the average age going into it was just under 42, but there were a number of individuals who were in their 60s going into this, and I think there's no reason why it wouldn't work if you're in your 60s or your 70s or if you're 20 as well. So it's the same process. And interesting, actually, the data in the most recent one actually looks at people who are sort of 40 to 60. They seem to have even less bleeds than you'd expect afterwards. So I don't know if it's just because it's small numbers, but then everyone has different needs at different ages as well. So it's sort of, with making that choice, if you're in your 20s, your 40s, your 60s or 70s, that balance between what the benefits and risks are will very much vary, I think.
Great, thank you. I do keep typing your questions. I've got some more that have been emailed in. This one's about consent, actually, informed consent. I'm not sure if Munir, if that's something along your line at all, but the question is, or anyone else really to answer, can informed consent ever be truly given to a procedure that is so complicated as to be incomprehensible by a layperson? I certainly think the whole complete mechanism is very incomprehensible to a layperson. As a layperson, I can say that. And I think we all have different degrees of understanding. So that's a very interesting question about informed consent. Who wants to take that one forward?
I'll have a quick
I,
stab at it.
Oh,
I
go on.
mean, I can drive a car, but I could not explain to you how the internal combustion engine works. You don't always need to understand all the technical details. You need to understand the basics, what it is, what it is not, how it probably works. I think people get worried that they can't understand all the complexities in a different language. And also the fact in any patient population, you're going to have people with a high degree of education and interest and scientific knowledge, and you're going to have people with a very basic level of interest. So I think you have to cater for all of those people. As haemophilia societies, we have to produce different pieces of information for different people in the community. You can't give everybody the same information in exactly the same way and hope they'll absorb it.
the only thing I'd add to that is that informed consent doesn't mean that you know everything. I don't know everything about gene therapy. So what's important, if I'm discussing with a patient, is to say what we know and what we don't know. And I would consider that informed consent. So even though there's a lot we don't know, I've touched on what we don't know about any cancer risk. It's important that is explained to the patient when they're giving informed consent, how likely it is to work, or that we don't know how likely it is to work. I completely agree with Brian. There are patients who want to know a lot about the science, and there are others who don't want to know a lot about the science, and it's gauging that, and that's what I would consider to be informed consent.
Okay, thank you.
If I may
In,
just add to that, I was given the Hemophilia Society leaflet about gene therapy, and I think it's really well explained for people who are not in the medical sector. Um, and it covers a lot of what my experience has been with the gene therapy. So if the best information you could get is from that leaflet, I would say, for someone who doesn't really understand the science behind it.
Thank you, Joseph, and thank you for promoting our leaflet. Yeah, it is on our website, and I'll, perhaps Naomi, if you can hear, you might be able to just put the link in the chat for everybody that wants to have a look. Just a question here about, does gene therapy put you in the normal range? I'm using inquisitive normal range of factor IX levels. My son's trough is currently about 20%. His factor IX infusion times or 2 times a week. I think that's a bit of a difficult one because we don't always know for everybody, but Catherine, Paul, do you want to stab at that one again?
So the average levels in the first year after the current treatment were around 39%, and it's so 5 years on that graph that me and Brian were chatting about, it's about 36. I think one thing that's important to think about with this gene therapy is that there is variability that people get. So some people get something that's on the average, some people get things that are above the average, and some people get things that are below. So within this, some people did have levels that were over 50%, so in the normal range, but some people did not as well. So there is a variability that you see, and this is because everyone's an individual, and there's no way of tweaking this like you might tweak a dose of prophylaxis to target a trough level. It's once it's in, the body then makes the factor IX at the level that it's able to do it at. So I think some people do get normal levels, but some people maybe more average or maybe slightly below as well. I mean, Brian, is this something that we're talking with people?
Yes, I mean, one thing that worries me, Paul, is sometimes if people with hemophilia look at gene therapy results, they will only look at the mean or median. So if you say 36%, they say, "Whoa, I get 36%." And I think what are very useful are the pie charts the companies show. So, for example, the last piece of data on the factor IX gene therapy showed that these are the 54 people who were on the clinical trial. 17 were between 40 and 100% effectively normal. 26 were between 12 and 40%. That's mild. Another 5 were between 5 and 12%. 2 people did not get a response, and we know why in their cases. And there were 4 people who didn't have data because, well, 2 of them had passed away from other causes. So I think the majority of people were either in the normal range or the mild range. And there were very few people who got little or no response. And I think that's what people need to understand. It's not the average is an average, but that there's quite a lot of variability in between that.
Great, thank you. I'm just going back, James. Yeah, sorry, you did drop off just as we're answering your question about haemophilia A. No, I'm afraid it's not available anymore. It was available in the US and Europe for a while, but no, there isn't any haemophilia A currently available gene therapy. So if you go back over the recording when it comes out, you'll probably get the full answer. I'm sorry that you missed that one. We came to your question when you just dropped off for a moment. I've got a couple of other questions that have come in. One said, will I be infectious after I receive a virus-based gene therapy?
No.
I suppose it's because at the end of the day, it's a viral vector. So people sort of, I suppose that's part of the understanding that you're giving somebody, but it isn't a live virus, is it? So
Yeah, and well, it's not really a virus at all, to be absolutely
it's a
honest.
capsule, yeah.
It's basically the sort of outer coat of the virus with tiny, tiny bits of the DNA of the virus in there, but it can't replicate. It's not something that's contagious. It's not something that's infectious. If anyone on the call's been sort of reading around this, you'll know that that you can't donate sperm or blood. Or you can't donate. You can't have a child for the first year, and that's not because you're infectious. It's because there is a little bit of residual, or there can be little bits of residual bits of DNA in there, and it's just an absolute caution to be absolutely certain that there's no genetic material going where it shouldn't go. That's why, but it's not infection. Sorry, it's quite a difficult thing to explain, and I hope I haven't confused anyone, but there's just little bits of genetic material that we know in the clinical trials was in semen for the first few months, and that's why there's this caution. You're definitely not infectious.
Thank you. And that actually, thank you, Catherine, because that leads me straight into the next question, which is, can I have children after gene therapy? How long? Obviously, you've mentioned about the shedding, but also will it affect them? I think people are thinking, does it actually change carrier status or change the genes that you carry on to your offspring?
Yeah, so it absolutely does not go to your offspring. So if you have gene therapy, whether it be successful or not, your daughters will still be carriers. That will not change. So the gene is still passed on through the family. But the gene therapy you receive, that in a good way, it also doesn't pass to your children. So yeah, so basically, if you decide to have gene therapy, it will not affect your children in any way, physiologically, biologically.
Okay, thank you. No, I've got a couple of questions from somebody who I believe has been through gene therapy a while ago on a trial, and I'm going to read this out because I think I should, because I promised. But it said, given the sad history of haemophiliacs exploited and used as guinea pigs by doctors and pharmaceutical companies, does any of the panel believe that in a rush to market will patients actually be put first? I think this is the balance of bringing things to market that aren't fully tested. I mean, I'm just putting that opinion up. Brian, it might be worth coming to you on that one.
I mean, I would not use the phrase rush to market with gene therapy. For example, the currently licensed factor IX gene therapy, it's been licensed for over a year. There are 9 years of data on that from the phase 2B trial, 9 years. And with the UCL trial, there's about 13 years of data. This is the exact opposite of rush to market. They've been very careful, very slow. And in fact, even the rollout, when the gene therapy was licensed, the number of people taking this was quite slow initially, and it's gaining momentum now, but it's still a very small number of people. And I think that's because people sensibly are saying, well, I'm very interested in this, but I might wait a year or two and see what happens in the real world. Or people are taking their time, and I think that's good. We're all fully aware of the tragic history in the past with HIV, hepatitis B, hepatitis C, variant CJD. This is entirely different. This was not a rush to market. It was very well thought through. The trials were very well put together and carefully monitored. And I think people will be monitored on an ongoing basis. And I can tell you that the clinical trial period was 5 years. My 5 years was up last year, and then I was quite pleased to go into a 10-year extension. So I'm being monitored for 15 years. And I think Paul and through Catherine would agree that people who've had gene therapy should be monitored for life because that's also the only way we'll get really good long-term data. So I would dispute that the phrase rush to market. This has been very carefully and slowly done.
And if I may add to what Brian said, as a patient who recently received the gene therapy, um, I've I've been told about it since I've been 16 years old, and I've been, in a sense, waiting. Um, and it's been a very slow process, but I think it's very important I've been treated really, really well at the Royal Free, and it was entirely my decision. I've not been pushed to do anything that I did not want to. Um, so I think it's important to say that it's been really well done, and the experience I had was nothing but positive so far.
Thank you, Joseph. Does anybody else want to comment on that, or shall I move on to the next? Okay. Um, we just I know that I've spoken to a few people as well who when they first had gene therapy have had to take some steroids for a short period of time. Do you want to sort of explain what's happening there and why that might be something that people have to experience?
I think Paul and I sort of balancing who speaks next.
Oh, sorry.
No, it's fine. It's fine. I steroids. There's no doubt about it. Steroids are tough. They are tough, and but we do know that if we see the liver getting a little bit inflamed, which we know happens, it does happen in a good proportion of people in the clinical trials. We know that if we see the liver getting inflamed through the blood tests, that if we start steroids promptly, we can bring that inflammation down and we can allow the gene therapy to keep working. But there are side effects. I don't know if anyone here has ever had steroids before, but they make you terribly hungry. They can make it difficult to sleep. They can make you irritable. They can make you tearful. And they're generally weaned down quite slowly. So I think in the trials, the average was almost heading towards about 3 months that you were on steroids if you needed them. So, I mean, what I say to patients I look after, whether it be haemophilia or anything else, is I tell them steroids are quite rubbish, but they are highly effective. And I think that if you can just warn people the worst case scenario, I think it helps a little bit to tackle it. But, talking about work-life balance and having to come to the hospital twice a week, if you're on steroids as well, I think patients need to be really prepared for that because it's going to be tough having this whole emotional experience of perhaps a life-changing treatment, and now you're making them feel irritable, grumpy, and wanting to eat a packet of digestive biscuits every day. So it's and they may gain weight. I mean, that's the other thing, it's quite it can be really, really tough. And in the clinical trials that we've run in Glasgow, probably half our patients have had steroids and half haven't, and they don't like steroids, so it's a bit tough.
Yeah, just to add, so within the studies, it's about 1 in 5 people for this that needed to have steroids. So it's not as much as some studies, but it's still, and I'm sure Joseph will sort of agree that it's something we had quite a lot of discussions about in terms of going into the treatment, in terms of, because it does have many implications for a good period of weeks over that time when you're on them. And some people feel fine on them, but some people feel really rotten as well during that time.
Yeah. Yeah, thank you. Also got interesting, very, very specific question coming. I really don't know if you can answer this, but I'm going to ask it anyway. So somebody said they've just moved on to mostazumab, which is obviously a subcutaneous once weekly prophylaxis. And great to hear you've had a massive improvement. Would gene therapy therefore decrease the possibility of bleeds? I mean, that's a very new product, so I think I don't think we've got any data on that one, but can we answer that one at all?
Well,
How would you answer that if somebody came in and spoke to you about that?
I can give about that if you want.
I haven't had any bleeds since I've had my last bleed I had was 2 days before my gene therapy, and I haven't had any bleeds. Obviously, you can't do a lot of sports, but I haven't not had any bleeds or anything related to hemophilia since I've had my gene therapy. and my levels have been around 25 to 30 since Christmas. So I don't know if that helps.
Thank you.
Yeah, I mean, I think it gives a good example of what happens with stable factor nine levels, Joe. I think this one is a really complex question from a choice, and it's nice that we have many different choices available compared to what we had 10, 15 years ago. I think the big differences between the two is one is reversible, which is the marstacimab, and the gene therapy is irreversible. And the other big difference is that the gene therapy is producing factor nine, whereas the marstacimab is just kind of tweaking the clotting system as well. So there's a difference between having levels which are what you should be making compared to sort of adjusting things. And I think it's one of those things in terms of if looking at the options, sort of sitting down and looking at what both different directions mean and what are the benefits and what are the potential concerns, and sort of balancing which of those are most acceptable and which one are sort of no-goes. I mean, Brian, this is a complex area. Any thoughts on this from your side as well?
I've spoken individually to several of our members who are thinking about or not thinking about gene therapy, and I've ran them through a fairly lengthy discussion matrix. And one or two of them they were with needle phobia or really bad veins, were thinking I'm very interested in gene therapy, but I would also consider a subcutaneous treatment. So as you said, Paul, you've got marstacimab, you've got concizumab, which are both licensed. As the third one, fitusiran will be licensed probably in a year to a year and a half. So there are subcutaneous options coming along. But of course, as you well know, these also have potential side effects, things like thrombosis. So none of these are entirely risk-free, and I think it's all a question of balance, isn't it? I think with gene therapy, if you get a good expression, and Joseph has told us he's got a good expression, I've had a good expression for the last 6 years. So then you're getting a steady level with factor nine gene therapy. You're getting a steady level that can help your joints. And also, I mean, I've had two minor bleeds, very minor bleeds in 6 years. I've needed factor for things like surgery and so on. But I also had a couple of situations where, you know, sort of on one stage I was out hill walking with my wife and children, and I slipped off a low wall and fell onto some rocks. It was only a small fall, but that would 100% have been a bleed in the past. It didn't bleed. A couple of things like that. That's a very nice feeling when you know this would definitely have been a bleed, and suddenly it doesn't happen. But I have got a couple of minor bleeds, but two bleeds in 6 years is not bad.
Joseph, you've had a few of those episodes as well, and you would have definitely had a bleed as well. I think we talked about as well.
Yeah. Yeah, well, I had a pretty bad back pain, and I thought it was a bleed, but we by precaution we did the scans and everything, and everything seemed to be fine. It was probably just a muscle spasm, and that's I think the most difficult part for me is to rediscover my body, and sometimes I would I don't know hit myself or feel a bit of pain in my joints or in the muscle, and I would expect it to for it to become a bleed, and it just suddenly doesn't. So it's more. Yeah, so I've been running quite a lot of a fair bit, and I've not had any ankle bleeds or knee bleeds or whatever. So um, it's been good. So I haven't had any bleeds yet. So cross finger, we'll keep it like that.
Great. One thing actually that we haven't talked about, and I think so I know Brian and quite a few people know of somebody who now has a job in a very remote part of the world who had gene therapy. And so the impact you have on looking at travel and having to take everything with you, I mean, is this sort of opening up your eyes to actually releasing you from having to pack all your stuff, get to airport security, take various letters? I mean, how's that changed you, Brian? You've probably got a bit more
Well, I
insight.
mean, I was traveling an enormous amount. The year before COVID, I did 45 trips abroad. So I nearly should have bought a house at the airport. So when I'm traveling, what takes most time packing was the factor and all the cables and plugs and chargers we all need nowadays. Now I don't bring factor with me. If I'm going to a developing country for more than a week, I might bring a box of factor just in case. But it's wonderful not to have to bring it with you. And it's amazing how quickly you get out of the habit of think you're bringing a factor with you. So that's a really nice side effect, if you like, not having to travel with factor all the time. But also, it frees up some hard drive space in your brain. Because if I was going on a 12-hour flight somewhere, oh, so I better take my prophylaxis this morning before the flight, not tomorrow, and change this around. And even subconsciously, you're going to the gym, you're doing something else, you're thinking about your hemophilia all the time. With gene therapy, if you've got a decent factor level, you don't have to do that.
And Brian, it's funny you say that because I just came back from a trip to Poland for work, and I did pack three boxes of uh, of treatment with me just in case. But it was so nice to be able to get through airport security on a normal time, so not aiming to go to the airport an hour before, not getting stopped and asking why I have all these liquids in my suitcase. I did have everything, the letter from the hospital and everything,
Mhm.
but it was amazing to experience it for the first time. I like to travel as well. 3 years ago, I went to Japan for 5 weeks, and the amount of treatment I had to take with me was a full suitcase and backpack with me. And so yeah, it's amazing to be able to travel without thinking about, like you said, treatment before I travel, and um, having to explain myself every time I go through airport security.
And I think the other thing that might change, not just with gene therapy, with some of the rebalancing agents, with really good treatments, is it's opening up more options for people in terms of their life, their sports, their activities, their career, their travel. For example, a lot of Irish people like to go to Australia for a year and backpack around and then come back. If you want to stay for a second year and you have severe haemophilia, you will not be allowed to. You'll be seen as a burden on the healthcare system. That may change with gene therapy. So I think it is opening up more possibilities for people. We now have these are not people on gene therapy, but the last 2 years we've had two people with one with haemophilia, one with von Willebrand's becoming policemen, which is unusual. So that there are different options opening up for people. So I think I'm seeing a mind shift in many of the centres where in the past you'd go in and they'd say, right, this is your treatment, how many bleeds you have last year, how are you getting on? And now it can be, okay, how are you getting on? What difficulties are you having? What would you like to reasonably do that you can't do? What are the obstacles for you? And then which treatment might best suit you? So it's turned it on its head to an extent. It's a very nice complex area to have.
Absolutely. Fantastic. Thank you. Just fire off any more questions. One thing somebody has asked about, and we're sort of going into the realms of research now, and I did see there was a comment again about research into haemophilia A, but the difference between this gene therapy and gene editing. I don't know if somebody wants to just explain roughly what that is or what's coming down the line. I don't know if Professor Mohammed, do you want us to come to that one at all?
Sure, yes, thank you very much. So, gene therapy, as has been explained, is to introduce this viral coating with the um, gene in there that's given as an infusion, and we heard how it can be so effective. Gene editing is different from that. It's a different technique which allows one to be able to change somebody's DNA. It's like a pair of scissors. It cuts out the DNA which is um, defective, if you like, and inserts a piece of DNA which actually works more normally. So it's slightly different. It's in gene therapy, you are providing the sort of vehicle to get the vector together with the gene. In gene editing, what you're doing is using very complex techniques to replace part of the DNA and produce normal levels of protein.
Thank you. And do we know, is that, I know that's coming in for haemophilia B, is there an option that that may be coming in for A as well?
Perhaps the specialists want to answer that.
So for the gene editing studies, there is a gene editing study for haemophilia B that will be available in centres within the UK. I'm not aware of anything immediately in terms of haemophilia A. Catherine, Brian, do you know anything that's sort of on horizon?
I think metagenomics are developing
Awesome.
hemophilia A gene editing. It's early, very early stages.
It is.
Preclinical.
And the only
I think Expression Therapeutics are doing something as well, but I think that's a stem cell editing. So there are things sort of preclinical coming down the line, but nothing that's in clinical trial at the moment. Certainly not in the UK.
There's been a few small studies using using stem cells, which one study from the US and one from India, but I'm not sure how those are expanding in terms of using either CRISPR or lentivirus, but I think that's still quite, I don't know where that's going.
I think the other thing just to say is there's many different types of gene editing, some of them far more invasive and many more side effects than others. As far as I know at the moment, we've just got hemophilia B with gene editing where we're actually putting it into a different gene, but we're incorporating it into something called the albumin gene, which is you have lots of spare albumin, so you can take away about 1% of your albumin and use the gene to make factor IX instead. And there's some complex sort of enzymes that cut the albumin gene, and then the factor IX gene can go into it. But then there's other things where you have something almost like a bone marrow transplant. So just for the audience, you might read about gene therapy, say for sickle cell disease. That's very, very different to the gene therapy that we've currently got running in clinical trials. This is all clinical trials, the clinical trials that we've got running in haemophilia B.
Well, we have a challenge as patient organisations to try and get some of that information as it becomes relevant and comes closer to sort of dosing and trials, that we will be able to transmit that information in a readable form. So that's something that myself and Brian can look at as it comes along the line. But actually, for those people who are talking about factor 8 and haemophilia A, I mean, that has reminded us that there are lots of new things coming up, not gene therapy at the moment, but there are lots of other options. So, we'll probably look at running a separate webinar for those options, because there are a lot of different things coming on stream and later this year as well. So that's a reminder that we need to cover UP, everybody, and VWD as well. I know we're probably getting quite exhausted. We've been here a long time. Any other questions, please do type them in. But I did want to give you a chance to talk about some of the follow-up work that you're doing, Professor Pir Mohammed. Do you want to talk about what you're doing?
Sure, thank you very much. So it's been a very interesting privilege to be able to listen to people with the lived experience of hemophilia and lived experience of having had gene therapy. So I'm an NHS doctor, but I'm not a specialist in hemophilia. But what I look at is medicines. Medicines have benefits, and this is what we want to have, medicines with benefits, and Brian explained it very nicely. But medicines, unfortunately, also have risks. And what we look at is the benefit risk, and we want to maximize benefits and minimize risks. Unfortunately, all medicines, when they develop, do have some degree of side effects. In this case, the one that we're working on is where your liver becomes inflamed. And what we're trying to do is to understand why the liver becomes inflamed in some people, but not in others. I was glad to hear that Joseph didn't need steroids, which was great, but other people do need steroids. So if we can understand what's different about Joseph, that he didn't get the liver inflammation while others do get liver inflammation, it provides us ways of being able to prevent that liver inflammation so that we are maximizing benefits and minimizing risk. In that way, what we're trying to do is to improve the benefit-risk balance that Brian talked about. So research is very important in terms of safety whenever somebody receives gene therapy, so that we can try to improve the safety aspects all the time. And when gene therapy is licensed by the regulator, and the regulator does an enormous amount of work to make sure the therapies are as safe as possible, the regulator also wants the companies and clinicians that are using this to monitor patients very carefully, so we can understand what happens in terms of side effects over the long term. And by understanding that, understanding why some people get these problems, we can develop ways of being able to prevent these problems from happening in the future, to make sure that you have the benefit and minimize the risk.
Thank you very much. Thanks. Just one question that's come in. Again, I'll turn to Paul and Catherine on this one, the treating clinicians. What will happen if gene therapy didn't work? Would you go back to your old treatment, factory replacement, or instead of bypassing agent? Well, I think I know the answer, but I'll leave you clinicians to answer that one.
So yes, you could go back to the same treatment. It wouldn't make any difference. It should work just as well as it did before.
Yeah, thank you. Somebody would like to have your brief perspective on gene therapy for VWD. I think I've heard things around one of the conferences, but I again refer to anybody else that has a better memory for me on what's happening with VWD gene therapy.
The only thing I actually don't know much about that area. One thing I would say though that I think could be a challenge is that one thing about the von Willebrand factor gene is it's really big. Maybe Paul knows more about this than I do, but it's very big. And so one of the problems with haemophilia A was trying to get the factor VIII gene into a viral vector. I presume squishing a von Willebrand factor gene into a viral vector would be really tricky. But I don't know, Paul, whether you've heard anything more about where we might be going with that, but I confess I have not.
No, I've heard people talk about it, but I don't know any specific details. I don't know if Brian's been following this in any detail.
Yeah, I mean they talked about using two vectors for von Willebrand and some gene therapy work, but it was very, very early stages. And frankly, there are so many potentially exciting new therapies for von Willebrands coming down the line. I counted seven at the last presentation, some antibodies and subcut treatments. I wouldn't even think about gene therapy for von Willebrand. There are some really, really good treatments will be available, I think, in the coming years. And I don't expect gene therapy to be one of them for VWD.
No. And anybody that is really interested in that, it is an in-person event, but we have a VWD event in Liverpool on June the 13th. If it hasn't come out this week, it's coming out this week, and that will be on the table there. So anybody who can get themselves to Liverpool, who wants to talk all things VWD, then that will be out later on. Thank you. Interesting question. At what pace do you want to make the treatment available, and how do you select people? I think that means incentivize people. So
these are really, really long conversations. And I think Joseph's demonstrated that really, really clearly. And I think as clinicians, we're also very aware of this as well, is that we don't want to rush. So we want, first of all, the patient to be absolutely fully aware of the risks and benefits and exactly what they want out of it. And those conversations can go on really for quite a long time, because one of the things that we've realized as clinicians, we sort of knew, but we've really realized, is that haemophilia A and B have very effective treatments. They're not perfect. People still bleed, but they are very effective. And so when you're looking at a treatment that's very new and is it going to work? Is it not? Are there any long side effects? Are there not? What effects is it going to have on me for that first year? They may just want to really think about it and really see and keep seeing what's developing. So I don't think Paul or I would sort of say, yes, I reckon by the end of 2026, we will have dosed 20 people. That's our aim. That's definitely not our aim. We just take it one patient by the next patient. Paul and I are on we have something called the UK Gene Therapy Panel, which is basically clinicians coming together to sort of bring all that knowledge of all the dosing centres, so that we can learn from each other as we dose each person, and that's what we're trying to do, is just do it really, really slowly and really learn as we're going on, even though it's we know it's safe and efficacious, but once you have something in the real world, you learn lots of new things.
Yeah, I
I'd
agree.
say as well sorry, Paul, go ahead.
Just to say, there's absolutely no rush as well. I'm sure Joseph will say how many times we sat down in the run up to talking about gene therapy, about different aspects and sort of the plannings and logistics, and just it really sort of, and in terms of selecting, I guess it starts with that discussion about what's available at the moment and what might be available. And this is one of a number of options as well. It's not the only option.
I'd like to say as well that I think the UK HCDO have taken a very methodical approach to this, and there are guidelines. But to me, if somebody is considering gene therapy and if he's in discussion with the centre, personally, I think there should be at least three separate discussions with a period of time in between each one for them to come back and think of issues and cover various things. I would be, and as a patient organisation, we're doing a lot of education with our members as well. I wouldn't be worried about the man who says to me, I've got no interest in gene therapy. I'm doing great on extended half-life factor 9, no interest in gene therapy. That's fine. What would worry me is the guy who says, "Oh, I absolutely want it. Do you know how it works?" No, no, but I just want it. Sounds good. So they need to have, it needs to be a fully informed personal decision. And once you make sure they cover all the bases and understand what they need to understand and link in with the centre and do those meetings with the centre, then they're ready for a decision. Because this is irreversible, like, unlike any of the other treatments. And as Paul said, you can go back to your previous treatment if it doesn't work, but you've used up your one and only chance to have gene therapy. So I think there's no rush. To me, it would, if somebody is quite keen, I think the discussions with the centre might take, what, at least 3 months to get them to the point where they're ready. They also need to, and as Joseph pointed out, and I found the same, it's all very well saying I'm ready, but then you got to look at the visits, the monitoring visits, the schedule, the dates for those. How will that fit in with your college or your work or your employer? So you've got to actually plan your life around this, certainly for the first 3 months. That takes a little bit of doing. And I think, and there's no point in going into this unless you're committed to doing the follow-up. So I think it is a process. It is a process of discussion. I think the haemophilia societies, in my view, can play a strong role in also helping to get the patients ready for those detailed discussions with the clinicians. I did some workshops in the States, and there were some people who were really, really knowledgeable, and some people really, who had a shocking level of lack of knowledge about this. One person asked me when I had gene therapy, how many weeks was I in hospital, and did they have to kill off all my white blood cells? And this is the kind of, information that's out there sometimes. So people don't realize what the process is. They don't realize what the follow-up is. They don't realize what they need to do. So it's an education. It's at least a 3 month job in my view, maybe longer.
It definitely took a bit longer than that for me. I think Dr. Batty and I we sat down a few times over the course of well, now I would say it'd be more than 2 years ago. So and I had my treatment in November, so about a year, more than a year before my treatment, actually the treatment day, I would say.
Absolutely. An interesting question. Do you exchange and learn from your colleagues in Europe about their experiences? I mean, I've been working in haemophilia since 2010, I think it was, on and off. And I can't say I don't think I've ever been to a conference, International Europe, or where gene therapy is not talked about, discussed, and has been debated for all of those years. And absolutely, comprehensively, always. I mean, it got to the point where I think it got to the point of gene therapy overkill, I think, in some of the conferences a few years ago. I think we've got a good, happy medium now, but I can see nods, so I'll let some of the others answer that one.
We had the World Congress in Dublin 30 years ago, 1996, and the theme was From Care to Cure, and there was a plenary on gene therapy given by Glenn Pierce. So it's only taken 30 years to get to this point.
Yeah, there's a lot in the European side of things as well. So I volunteer for the European Haemophilia Consortium as well, and this is on the agenda with sort of sharing experiences from different countries because it's a complex treatment for everyone involved. It's not something that's as simple as a tablet, and having those different learned experiences from individuals, from clinicians, and different centres is critical.
And there's never going to be a huge number of patients either. So here we are, we've had these international trials where we've got sort of 50 patients in long-term follow-up. So as we're now bringing this now into, the healthcare systems, we need to get as much experience as possible and share that experience, so that we can learn. And this is where the databases are so important, so that we get all the information together and can learn as quickly as possible. And if we, it just wouldn't work working in silos, because then you wouldn't be able to find out the information you need as quickly as possible. So yeah, there's great collaboration and great sharing of experiences.
Yeah, there's somebody's mentioned about places like China, India, and Europe and the US to run reliable trials. I mean, there's already been lots of trials in the US. I believe there's been trials in China as well. Does anybody
Well,
comment on that one?
there's a licensed factor IX gene therapy in China. It's licensed in China. It's not licensed by the FDA or EMA, but there is a licensed factor IX gene therapy in China. The results look reasonably good, and I think they were marketing that at about one-tenth of the cost of the currently licensed gene therapy.
Fair enough. I didn't know that one. Thank you very much. I think we're drawing towards the end now. I've got one more comment down there. I should say thank you. Any last comments from anybody before we go? Paul, Catherine?
As I find with every single patient meeting, it's just fantastic to hear about patients' experiences. It doesn't matter how long you're a doctor for. It just shines a new light on things, and you learn about it from the other side. So huge thanks to Brian and to Joseph for sharing that. Thank you. It's been great, and I hope Paul and I have been able to explain a bit of science along the way and not be confusing.
Could I just say as well, Deborah, that we were considering as our educational model for factor IX gene therapy, it's a small country here, geographically it's not huge. So we were thinking about small group meetings rather than big meetings and doing individual consultations with people using a template that we've built. But recently we did a series of 4 podcasts with the Canadian Haemophilia side. They're all actually on our website at haemophilia.ie. But what was very interesting was one of the podcasts was 4 men, 3 from Ireland and 1 from Canada, who were either considering or not considering gene therapy. And they loved the small group discussion. I mean, I was very relieved because the podcast went really well, but they loved the discussion. And then we had a separate podcast with 4 men who'd had gene therapy. So I think those small groups are a really useful way as well. So as well as people with hemophilia going to the centres and talking on several occasions with their clinician and talking to the Haemophilia Society, I think there's a lot to be said for small group discussions. Because in that situation, 3 or 4 people even, somebody will say something or ask a question that the others hadn't thought of. And that group dynamic gives you a lot more information. And also you feel, I think sometimes people say, I went in, I had a really good discussion with the doctor. When I left, I remembered I'd forgotten to ask him this or that, or I didn't quite understand this. In a small group discussion, if you have a clinician there as well, what can happen is somebody else asks the doctor a question, they answer it, and that answers a question you didn't even know up to that point that you had. So for something like gene therapy, I think adding in small group discussions could be really valuable.
Thank you. That's really useful. And we'll have a catch up on that one and how we can make that happen for people.
I'd love to take part in that as well if that can happen.
Great, thanks, Joseph. And we have in touch with a few other people who've been through gene therapy as well. I love the fact that everybody's so generous with their time and they want to help everybody else and help other people talk through things, make decisions, and what's right for them. So thank you so much, all of you, for coming along and helping tonight. It's been absolutely fascinating. It's been really useful. I said there will be a recording of this. Naomi, you can stop recording now, and we will get some subtitles on it so it's accessible for all.